Good evening, everyone. My topic today, I'm going to speak on clinical immunology and hematology. And my moderator is Dr. Shruti Tapiawala and panelists Dr. Puneet Mashru, Dr. Joyce Vegi, and Dr. Samesh Shah. So in this session, we are going to cover mainly a topic like SLE, the newer drugs for it, immune thrombotic thrombocytopenic purpura, definition of massive blood transfusion, and also the role of IVIG in sepsis. So first we come to SLE, which is a highly heterogeneous disease affecting all organ systems, having a very unpredictable course, mainly affecting women within the reproductive period. And this is the first paper which I'm going to showcase. This paper was published in July 2023, and it mainly focuses on the current treatment approach, emerging therapies, and new horizons in the treatment of SLE. So, while treating SLE, initially immunosuppressants were used, like hydroxychloroquine, glucocorticoids, azathioprine, methotrexate, mycophenolate, cyclophosphamide, calcineurin inhibitors, and IVIG. Now, when they were used, there were a lot of side effects like flaring up of SLE, broad immunosuppression caused by these immunosuppressants, and there is target organ damage as well. So, to mitigate all the effects, biologic agents have come for as a part of treatment in SLE. So these biologic agents, they mainly include B cell targeted agents, interferon inhibitors, interleukin inhibitors, and JAK inhibitors. Out of these B cell targeted agents, the most popular is the rituximab. So rituximab is a B cell depleting anti-CD20 monoclonal antibody which induces B cell apoptosis and reduction of proliferation. It also treats refractory SLE and is beneficial in the treatment of arthritis and thrombocytopenia. However, the side effects of rituximab include flaring up of SLE, and it is not very useful in treatment of proliferative SLE, disease of SLE, but it is effective in mainly class 5 lupus nephritis. So another drug came in 2019, which is called belimumab. So belimumab is an upcoming drug and it is currently trending also. It is a fully humanized monoclonal antibody against lice, CD257. It is the first agent to be approved by the FDA for SLE over a period of more than 50 years. It was initially used for lupus patients without renal involvement, but nowadays studies have come up which show promising results in lupus nephritis as well. So now there are a lot of trials going on which involve the sequential use of rituximab followed by belimumab, and also the concurrent use of belimumab and rituximab, and those trials have shown very promising results, and they also show a possible synergistic effect. Other drugs have also been tried, like atacicept, which is an antagonist of BLyS and APRIL-mediated B-cell activation. But however, this drug is not very favorable for SLE patients because a lot of deaths have occurred because of alveolar hemorrhage in the context of pneumonia. So there were some newer drugs which have come like blisibimod and ipratumumab. But these drugs are also tried and tested. Blisibimod have found to be effective only in lowering the steroid dosage. But ipratumumab, though it has been used in a few trials, but has not been able to achieve the primary efficacy endpoint yet. So there were other drugs as well, obinutuzumab and ofatumumab. Ofatumumab is a fully humanized anti-CD20 monoclonal antibody. However, it is mainly used in lupus patients intolerant to rituximab infusion. So we have another class of inhibitors as well, Bruton's tyrosine kinase inhibitors. It is tried in a phase 2 trial currently, fenibrutinib. And nowadays the trials are going on The trial has not reached its primary endpoint. However, some beneficial effects of fenebrutinib have been demonstrated in SLE. Bortezomib, a proteasome inhibitor, has also been tested in some animal models of lupus, and recently it has been tried in severe refractory lupus nephritis and has shown good results in SLE. The next generation of drugs which have come out in the treatment of SLE include the interferon inhibitors. Among the interferon inhibitors, the most prominent is anifrolumab. So this drug has also been approved by the FDA for moderate to severe SLE, but excluding the patients with lupus nephritis or central nervous system involvement. However, the most significant adverse effect with this drug has been found to be herpes zoster, and so this drug has to be used very cautiously. Interleukin inhibitors have also been tried in the management of SLE. Tocilizumab, secukinumab, and low-dose interleukins have been tried. And last is JAK inhibitors. Among these, baricitinib has been approved for the treatment of rheumatoid arthritis and is being evaluated in active SLE patients not responding to standard of care treatment. In these SLE patients, the resolution of arthritis and rash was observed. However, a high rate of infection was found. So, what we have concluded from this paper that with the introduction of rituximab and belimumab, biologic agents targeting the B cell has opened a new era in SLE management and has extended the therapeutic spectrum in all subgroups of lupus patients. And more work is needed to further incorporate therapeutic developments in SLE treatment and to ensure improved quality of life in SLE patients.
So, Puneet,
Yeah,
here's a nice paper which I think Chandrima has brought up. But before we go
correct.
to that, can you just, from a critical care perspective, what are the important concerns you have when your SLE patient gets admitted to ICU, and a brief primary treatment you offer, and
Correct.
then we can talk about this paper.
Yes. No, it's well presented. So I'll just tell you about, so when a patient of lupus admitted in ICU, there are a couple of things that we're looking at. Are we dealing with lupus flare? Are we dealing with infection? This is a very important thing. So that we have to differentiate in lupus. Am I audible?
Yes, sir, you are audible.
Yeah. Yeah. So are we dealing with disease activity? Are we dealing with infection? Now, that is a very common problem that we face often in our practice in ICU patients, in sick lupus patients. Are we dealing with both infection and lupus activity both together? That also we have to be concerned about. There are few clinical pearls I'll give you that we use in practice to differentiate disease activity and infection. One is that generally, if lupus is active, you will have cytopenias. Clinically, you will see the typical malar rash. You will see oral ulcers, the palatal ulcer. So we look at the palate, and you can see the palatal ulcer. That's very, very classical of a disease activity. Look for vasculitic rash on the hands and the feet. So clinically, this is very, very important in your lab parameters, cytopenias, then low complements, proteinuria. These are the things that tell you that this is the disease active. Now, how we differentiate disease activity and infection, basically, ESR can be high in both, but CRP may not be very high in disease activity. So we use CRP as a marker for sort of differentiating infection from disease activity. That is, though it may not be useful in certain scenarios, like if they have a lot of pleural effusion or something in serositis, CRPs can be very high. But otherwise, it's not a bad marker to help, which helps us to differentiate disease activity and infection. Now, in terms of the paper that has come, we have gone through so many of these newer molecules, which most of them are not available in India, including belimumab. Practically, with rituximab coming in the play, In severe disease, rituximab works very well. So if somebody has, it's not very often that we see that somebody has worsened, lupus has flared up, even though giving rituximab. Though it can happen in some patients, but generally that is not the case. Um then yeah, so that is what it is. And in terms of the rituximab, it is so lupus management depends upon the organ involvement. Now, generally, when we have uh, organ involvement in terms of kidney, alveolar hemorrhage, like so in the lung, or we have mononeuritis multiplex, so very high disease activity, or CNS lupus. These patients need pulse steroid with either cyclophosphamide or rituximab. So we need to give these agents in this situation. Like so in acute care, typically if disease is very active, we'll be using rituximab or cyclophosphamide. So yeah, any questions that you all have, I'll be happy to answer.
So when we use rituximab, of course, the decision is made to what are the baseline investigation we should have, and how do you administer, what precaution we should take? What are the basically contraindication I should look into it before I start a patient on a rituximab? And once I've given first dose, the first 1 week stay of post rituximab, what are the things I should monitor?
Correct. So before giving rituximab, we make sure there's no active infection. So as a baseline, clinically no active infection. We get certain blood tests done, which include complete blood counts. We get viral markers done, so HIV, HBsAg, HCV, and very importantly, we have to look for latent hepatitis B. So we get hepatitis B core antibody, IgM, and total. Okay, so this is very, very important. Sometimes they can be latent, and you give in latent hepatitis B. If we give rituximab, it's a disaster. Okay, so that is one part. We do serum immunoglobulin G levels. So IgG level should be beyond the normal range. Should be in the normal range before giving rituximab. If it is less than 3 grams, then rituximab is contraindicated. Uh, and when we give rituximab, the first infusion has to be given slowly, pre-medication of steroids along with antihistamines able has to be given. And we start very slow, 25 ml per hour, and we gradually increase to the full infusion rate. So, and yep, that's about it. And in terms of once you get rituximab, if somebody is tolerated well, generally there will not be an issue.
So, fair enough.
Okay.
Coming to Dr. Yeah, go ahead, Chandrima.
So actually, I have a question for Dr. Puneet.
Yeah,
What is the role of IVIG in the flare-up of SLE?
it's a very good question. It's excellent. So IVIG, one role is that if you have active lupus with sepsis, that is a drug of choice generally. IVIG works well to control the disease. IVIG, other situation is that you, for example, if there's myocarditis. So myocarditis is a very typical example where IVIG is given because it works very fast. And sometimes mononeuritis multiplex, or in other connective tissue diseases where there's myositis, so IVIG can be used there. But typically, IVIG is used in myocarditis and in sepsis. Sometimes we also use it as an add-on. Like, if, for example, a patient of macrophage activation syndrome because of lupus, we have pulse width steroids, we have started cyclosporin, and in spite of that, the patient is still, spiking fevers, still macrophage activation syndrome is active. We add IVIG as an add-on.
Okay. Okay.
I have a question. You have, Puneet, a patient who is immunocompromised, whom you need to give IVIG, and you have a patient who is immunocompetent, and you have to give IVIG. Suppose, for example, a GBS, and immunocompromised is some renal transplant patients. So, is
Correct.
there it is mandatory to do IgA level in both of
Absolutely
them?
IgA. Absolutely, yes.
And what will happen if if you're not,
It can cause
is it required in
anaphylaxis.
the both the
Yeah,
settings?
both the settings, very much. So always IVIG. Before that, we ask for IgA levels. If it is low, then it's contraindicated. Then I will not give it. It can cause
Okay,
anaphylaxis. Yeah.
okay, fair enough. Okay, Chandrima, we can go to the next
Okay.
paper.
Yes. So the next paper is based on immune thrombotic thrombocytopenic purpura. So immune thrombotic thrombocytopenic purpura, it is a rare hematologic disorder and it is characterized by episodes of microvascular thrombosis and ischemic organ damage. It is mainly caused by an autoantibody mediated deficiency of ADAMTS13, which is a von Willebrand factor cleaving protease. And this results in high molecular weight multimers of von Willebrand factor and resulting in formation of platelet aggregation and systemic microvascular thrombi. So this slide actually shows the evolution of immune thrombotic thrombocytopenic purpura from an acute fatal illness. It was basically discovered in 1924. The first case was reported, and gradually with the advent of various treatment modalities, how it gradually converted into a chronic disease. And if we see from 1924 to 2023, the relapse rate has also increased, the mortality rate has decreased, and the relapse rate has also decreased. The mortality rate initially was greater than 90%, and now it has come to around less than 5%. So, what are the risk factors for relapse in immune thrombotic thrombocytopenic purpura? The relapse rates range from 30 to 50%, and each relapse comes with the risk of significant morbidity and mortality. So, multiple risk factors have been identified, which include younger age, male sex, a non-O blood group, and black race. But the most important risk factor which has been found for the relapse is reduced ADAMTS activity. So much the ADAMTS activity reduced form is actually so significant that now the International Working Group in Immune Thrombotic Thrombocytopenic Purpura has incorporated it in its definition. And if the ADAMTS activity is less than 20% during clinical remission, it is considered to be an important risk factor. So next we come to the prevention of relapse. So there are different molecules which have been introduced for the prevention of relapse. One of them being rituximab. So nowadays, recently, preemptive rituximab has been used to prevent clinical relapse in patients with clinical remission but with ADAMTS relapse. So in this paper, the authors have monitored the ADAMTS activity every 3 months during clinical remission for most patients, and they have offered preemptive rituximab if ADAMTS activity is less than 20 to 30%. Other molecules which have been tried are cyclosporin A, especially in cases of patients who have been refractory to rituximab or have shown only a transient response to rituximab. Some other molecules like bortezomib, daratumumab, cyclophosphamide, and splenectomy have also been tried to prevent relapse in immune thrombotic thrombocytopenic purpura. Why we need to prevent relapses, and what is the main impact of immune thrombotic thrombocytopenic purpura? So now, since the survival has increased because of the result of these therapies, there are long-term complications of immune thrombotic thrombocytopenic purpura, starting from the cerebrovascular complications like stroke, transient ischemic attack, silent cerebral infarct, and also neuropsychiatric manifestations like cognitive impairment, depression, or post-traumatic stress disorder. This immune thrombotic thrombocytopenic purpura, it is also associated with many other comorbidities like hypertension, obesity, SLE, and other autoimmune diseases. It can also lead to cardiovascular complications like myocardial infarction, hypertension, and stroke. And in pregnancy, it can precipitate other complications like fetal loss and preeclampsia. So overall, immune thrombotic thrombocytopenia causes reduced survival, and the most common causes of death, premature deaths in immune thrombotic thrombocytopenia are basically cardiovascular or cerebrovascular. So what are the opportunities and what are the measures we should take to mitigate the risk and improve long-term outcomes in immune thrombotic thrombocytopenic purpura? First is ADAM-TS monitoring in these patients has to be done every 3 monthly, and preemptive rituximab is to be administered. We should identify optimal immunosuppression after a rituximab failure and identify the improved biomarkers for relapse. In case of stroke and cardiovascular disease, multidisciplinary care should be administered to the patient, and cardiovascular risk factors have to be identified, and optimal ADAM-TS activity targets also need to be identified. In case of neuropsychiatric sequelae, proper referrals for neurocognitive testing, screening for depression and mental health referrals need to be done. And in case of pregnancy, ADAM-TS monitoring along with platelet count monitoring is needed. The ADAM-TS monitoring in case of pregnancy should be done in every trimester. Best way to monitor is every month actually. So if there is vascular complications, low dose corticosteroids can also be given. And in case of severe complications, prophylactic therapy with plasma or immunosuppressive drugs can also be given. So in this case, I have a question. What in pregnancy, what are the drugs to be given for immune thrombotic thrombocytopenic purpura?
The question is for Dr. Samisha or me?
Any
So
one
I
of
will.
you, sir.
Okay, Dr. Samisha will be better placed. So if it is
Yeah,
lupus
sir,
or connective tissue
Dr.
disease,
Samisha
then I
has
will.
joined. Uh, I think
No,
Dr. Shruti
Gitan
has
sir could
joined.
not, Dr. Sameer could not join.
Okay, okay. Dr. Shruti has also joined. Actually, she's our transplant nephrologist and also immunologist. She has a state-of-the-art lab, and she's been taking a lot of academic sessions on immunology at various forums in the country. And welcome, madam, for this session.
Good evening,
And
everyone.
thank you for accepting to join this session at the last minute. So, madam, we were just discussing. We
No,
discussed
I
about
heard the case.
rituximab
I
in.
was there since 7:35, so I
Yeah.
had a last patient in OPD, but I heard everything.
Yeah, yeah. So
Hmm.
basically, what here, Dr. Punin and Dr. Shruti, we were trying to understand कि when we start suspecting patients with TTP or
Hmm.
clinically, how from there onwards, how to investigate these patients apart from the clinical diagnosis, and how to send these samples, relevant samples, to the lab. I'll come to Dr. Joycey because, madam, here is what we face. Like we make clinical diagnosis, we add order investigations, but where we get glitches is when our samples are not sent on the time, and when we don't, and the turnaround time of these reports are pretty long. So, Dr. Shruti, you want to overview about TTP in what is your experience of TTP?
So TTP is an immune condition, and if you find now TTP and TMA, now TMA may you do ADMT13, but TTP is a different syndrome altogether. So in thrombotic thrombocytopenic purpura, you might have a baseline immune issue which the patient will give a history from before, that they have a basically low platelet and occasionally steroids are used for it, as hematologists usually diagnose it based on the immature platelet function, and they also diagnose it based on the bone marrow findings. That is a TTP part, immune TTP. TMA is a thrombotic microangiopathy which encompasses a group of disorders which include atypical HUS, and it has thrombotic microangiopathy from different reasons. Atypical HUS is usually divided based on the hit factors. Like if you have a diarrhea and it is giving you HUS, then that is a typical HUS. Atypical HUS is that you have an upper respiratory tract, you already were a complement, um, you had a deficiency of complements, or you have enzyme deficiency, like you have CFHR mutations, you have mutations in the complement pathway, which is activating the complement pathway unnecessarily due to hits, then you might get a cascade of thrombotic microangiopathy known as atypical HUS. So this is a typical syndrome where a patient comes with a hypertension, will come with renal failure, with have a hit of say you have a sore throat or you have some infection which has triggered it. You can have thrombotic microangiopathy in patients with sepsis. You can have thrombotic microangiopathy in transplant recipients secondary to antibody-mediated rejections. So intestinal transplants, heart transplants, kidney transplants, these are the situations where there is a strong rejection, intestine transplant specifically, because you have a strong immunogenic response which comes, and the antibody-mediated rejection will cause vasculitis, and it will also cause a thrombotic microangiopathy. So sometimes if you see hypertension, you see platelets dropping, you can always get a thrombotic microangiopathy in this, and the treatment will be to treat the cause. So it's always important to identify what is the cause of TME. Sometimes the drugs which we are using, like calcineurin inhibitors, these can cause a thrombotic microangiopathy, and it is very typical. You start the CNIs, and within a few days, you will find that the platelets are dropping. And this will resolve by stopping it, giving giving a break to the therapy. Sometimes switching from tacrolimus to cyclosporin helps. If it is an ICU situation, which it is usually in, which you all are seeing, you all are managing multi-organ transplants, you all are managing sepsis. These are the two common scenarios you will be seeing. Transplant I told you about. In sepsis, what happens is sometimes you can get ADMTase deficiency, or you can get antibodies against the ADMTase. Now, the treatment for both of these are different. Like you said, Ketan, that you don't get these reports very fast. Now, that is a downside of it, but we can't help it because these are taking around 8 to 10 days. But the treatment remains plasma exchange with replacement with FFPs, because when Samir joins, he'll be able to tell us. But when you give FFPs, it gives you the enzyme which is deficient. And when you do plasma exchange, you're removing the antibodies, which are the detrimental antibodies. So I hope I have answered your question somehow.
Yes,
Yeah,
ma'am.
madam. Of course.
Yeah,
I think that's the initial approach. I
yeah,
think
Ketan.
I'll just take one comment of Dr. Joycey on this. Madam, are you there?
Yeah, yes.
Yeah. So in both the situation, how do you come across, and where do you play an important role, and what we should be aware, especially when we are dealing these patients in the ICU?
You mean the term of investigation? See, one is plasma. In TTPs, it's usually an acute condition. So plasma exchange, you can collect your sample and send it for your antibody levels oil, but it is an important thing that needs to be acted upon. It's said that even if you do not have time for a therapeutic plasma exchange to be done, patient needs to be transfused with plasma. High volume plasma is what is recommended. Now, so ideally, what they recommend is at least for the first 3 days, you do a 1.5 volume plasma exchange, and with replacement with either plasma completely, or it could be FFP. Some people use FFP with albumin, but FFP, or people even use cryopoor plasma. But there is no evidence that cryopoor plasma plays a better benefit than FFP, but you need a replacement of FFP. After the first 3 days, you could even use a 1 volume plasma exchange, followed, till the platelets have a maintenance. You reach a level where the platelets are maintained to about 1.5 lakhs. But coming to the investigation part, yes, These are enzyme levels, these are factor levels, does take time, takes around 10 to 15 days. The antibodies do come. But just because an antibody is absent doesn't mean it may not be an immune thrombus. It is seen that, the initial samples may not, but down the line you may see antibodies being picked up. That is what the test reveals. So tests sometimes you may not get, but if you're suspecting clinically, plasma exchange is to be started off immediately, because these are usually acute conditions, and that gives improvement. Dr. Shruti would be able to probably throw a highlight on this also.
So,
Yeah. So
now,
as soon as we diagnose a thrombotic microangiopathy, am I muted? No. So as soon as we see a thrombotic microangiopathy and we see the situation, plasma exchange with FFP will be the first line of action. Because till we get, so send off the samples, send off the ADMTase enzyme, send off plasmacytocytes, haptoglobulin, LDH. These are the markers, and the patient may have a renal dysfunction with or without hypertension. These will become a triad. And once you see this, you initiate plasma exchange. Till around 2 to 3 plasma exchange, you will be able to see the response. And meanwhile, you will get the test as well. Like Dr. Joyce said, fresh frozen plasmas will replace the enzymes. So it is important that you replace with FFPs initially. If you find out that there is no enzyme deficiency and you only have antibodies, then you might suffice with completing the 5 sessions of plasma exchange where antibodies will be removed. This should be, however, followed by rituximab. Why rituximab? Because rituximab is a monoclonal antibody which is going to prevent the formation of these antibodies. So you have to give plasma exchange 5 sessions followed by rituximab 375 mg per meter square. Sometimes you may have to go to 4 doses once a week. So this is how a treatment of TMA works. If it is sepsis related TMA, you treat the sepsis related TMA. You see what the reports come. Sometimes it is just ADMTase deficiency which is causing this. And there may not be antibodies. If there are no antibodies, you don't need to go to retux. It's just that you need to focus on finding the cause of TMA, and then the treatment is very simple. ABMR related TMA, the treatment will remain to be plasma exchange with FFPs. Because these are antibody related, you might want to follow it up with IVIG if it is ABMR related TMA. IVIG of 0.4 gram per kg into 5 to 6 doses to make it 1 gram per kg of dose of IVIG. This has to be next followed by 2 weeks later of retux, because you do not want the ABMR to come back, and then when you treated the cause, the TMA settles. Sometimes you might also see that the thrombotic microangiopathy starts resolving and with the first plasma exchange. So you know that therapeutically you have obtained. You might want to consider, I was going to bring up the complement inhibitor next. So I don't know if Chandrima you have read about it, but if you have a complement enzyme deficiency or a mutation in CFHR gene, which can cause TMAs, and you see that the complement levels are low, then that is a situation where eculizumab can be used. This is a complement inhibitor, and you have to use 900 mg per week, day 0, day 5, and then once a week. It is an extremely costly drug, difficult to get in India as of now, but it is available if we want. So this is one thing where if the TMA is not stopping, then eculizumab has to be used within the first 3 or 4 exchanges if we see that things are not settling and the complement levels are low. So that is the facet I'm giving you at this point.
you mean to say, madam, if your TMA is refractory to your first line therapy, Plex, plasmapheresis, and rituximab, when do you say it's refractory? Is it when the first line treatment has failed, or post rituximab? And how do you
So
assess that?
your
How do you
first line
monitor this?
treatment, when you have delineated the cause of TMA to be a complement defect, and
Mhm.
despite your plasma exchange and your retux, because in complement defect you will get anti-factor H antibodies deficient. So these antibodies deficiency means that you will have to give Ritux. Once that is given, if the patient does not settle down and the kidneys or the brain is at risk of getting damaged, because see, initially you will get an AKI, you might get a stroke, you might get a lot of things because of TMA, because TMA will cause a brain and a kidney injury immediately. If that is not resolving and the patient is dialysis dependent, then you will have to think of eculizumab right away, even before you use Ritux, because that is now coming up as a treatment of choice. I'm sure Puneet is going to be able to add to this because he must be using eculizumab in few cases. Puneet, you want to put in?
Yes, ma'am. Eculizumab I have not used. It's hard to get in India, and
So now it is
so,
available. So we have
yeah,
started using it. It is available
yeah,
now. So if you need for any patients, no, companies are providing it when
yes,
we tell them. It is
correct.
expensive. So you have to tell the patients that this is the expense, but it is a wonderful drug. There is one, so for Ketan and for the ICU people, one pearl of wisdom for using eculizumab. Eculizumab is a complement inhibitor, so you have to cover the patient with a meningococcal vaccine before you contemplate giving the eculizumab, because meningococcal meningitis is very frequent if the patient is not vaccinated for it. And when you give the vaccine, of course, the vaccine is not going to start working any which ways. So when you are contemplating eculizumab, you give the vaccine, you cover the patient for 14 days with the treatment of meningococcal meningitis. And once 14 days are over, the vaccine has kicked in. And that is how you use eculizumab.
Yeah, I just had
And madam,
sorry.
all yeah,
Go ahead. Go ahead.
go ahead, Puneet.
So just from the rheumatological point of view, when we talk about TMA, so lupus TTP is something very important. So that obviously when patients of lupus come, it's usually associated with very high disease activity. Uh, we don't want to wait for the entire pentad to be visible, because if the entire pentad comes, meaning we are very late in treating this patient. Okay, so we should suspect it very early with just hemolytic anemia and thrombocytopenia with some possible one organ involvement. Immediately, if you alert us that this is possible, this is a TTP. Now, for lupus-related TTP, along with plasma exchange, it is pulse steroid and rituximab. So there is one thing I wanted to say. Other differentials we have to keep in mind is that is one is scleroderma renal crisis. They also can have TMA. Okay, to identify scleroderma renal crisis, generally these patients have extensive skin tightening. So it happens very early on disease. It is generally associated in patients who have extensive skin tightening. You see Raynaud, you see digital pitting scars. These patients typically they will be on some steroids, which is possibly precipitated their scleroderma renal crisis. They have hypertension, heart failure, and other things. And the treatment for that is just blood pressure control. It's not plasma exchange in that group. The other differential we keep in mind is catastrophic antiphospholipid antibodies. So it is generally in females. Ask them for history of recurrent miscarriages. So that should alert you that possibly that this patient has antiphospholipid antibodies, and they have multi-organ involvement, these patients, and they can have lung involvement, they can have macrovascular involvement, which is not there in TTP. And the treatment for that is again is steroid, heparin, plasma exchange, and then immunosuppression.
Okay, sir.
To Joycey, I think you want to, from your experience with us in critical care, you want to tell us something which is quite important for critical care trainees and fellows, or where you see that some hematological investigation, like when we start, basically, a few example which we come across you is when we do this HLA testing, or when we do a mixing studies, or when we send such tests to you, what precautions we have to take when we are sending such important tests to you.
Basically, I think most of the tests we need to ensure that, like, like NHD typing that you cannot transfuse or multi-transfuse. You have to plan these samples to be collected prior to the transfusion. There has to be a gap because you have transfused lymphocytes, so you have leukodepleted blood going in. You have transfused lymphocytes, so you might have an error created there. Now, so even you send an ADAM-TS, if you transfuse a patient with FFP and then you send an ADAM-TS investigation, you're not going to get your original level. Not going to find out if the patient is actually. So you need to send your investigations prior to your transfusion or therapies that is started off. That is something that has to be taken care of. So you need to send your investigations before your management. So at least you clinically suspect something, send it before you start your treatment or transfusions, especially when you're transfusing foreign blood and blood products, it would create an error in your tests. That is something that
I want Thank you so much, ma'am. Dr. Shruti, I want your take on use of IVIG in sepsis. I think we have got one paper which was some sort of meta-analysis, and which has, because of time constraint, Chandrima, can you just quickly review this paper? And Dr. Shruti, if you can comment on your experience of IVIG in different settings.
Okay, let her go through the paper, then I'll comment on it.
Okay, so IVIG, this paper was actually published in January 2023, and it mainly shows the efficacy of IVIG therapy for patients with sepsis. So they included around 1004 studies, and out of these, only 31 RCTs they took into account. And the outcomes which they studied was mainly mortality at the end of the follow-up period, length of hospital stay, and also Apache scores. And what they found out is that of the 31 RCTs, 19 patients were given, 19 RCTs were actually entitled to standard IVIG, and 12 were IgM enriched IVIG. And mortality was assessed in all the 31 RCTs. And what they found that IVIG did play a great role in reducing the mortality. So this is the forest plot, and this shows that the role of IVIG in reducing the mortality. The results also show that IgM-rich IVIG was effective in treating sepsis. The subgroup analysis of this trial showed that the effect of IVIG, however, in reducing neonatal mortality was not that conclusive. And out of the 31 RCTs, there were 7 RCTs which were available, which actually documented the length of hospital stay. And in these RCTs, compared with the control group, the IVIG treatment group significantly reduced the length of hospital stay in patients with sepsis. And 5 RCTs also showed that it significantly reduced the Apache 2 score. So, in a word, this trial was actually a positive trial, and showed sufficient evidence to support the uh, to support that IVIG reduces mortality associated with sepsis. And among IVIG, IgM enriched IVIG has been found to be effective in both adult and neonatal sepsis, while standard IVIG has been found to be effective only in adult sepsis. Ma'am?
Shruti, yeah. So, Dr. Puneet, you have any comment on this?
No, nothing from the rheumatological point of view, no. Generally,
Okay. So,
IVIG in disease activity in lupus and vasculitis, we do use it if it's associated with infection or as an add-on therapy.
yeah, so IVIG has been quite debatable intervention, and the limitations to it use was, and which stage of sepsis if it is to be used, which stage of sepsis we have to use IVIG, and there is specific conditions where we can, it is shown to be beneficial, like toxic shock syndrome, there's a strong role that IVIG, but over a period of time, sepsis IVIG has been used in the sepsis, but even the surviving sepsis guideline has not given a strong support to use of sepsis, but still there is ongoing research. Now, this paper is being quite supportive to use IVIG in the sepsis, looking at
But
the
sir,
major drugs.
actually, this paper included only 31 RCTs, and we need more data to actually find out whether IVIG is
Yeah.
really that helpful in preventing mortality.
Sure. So there is a head-to-head comparison required for understanding the actual benefit. But as I said, the problem lies when to implement this therapy, at what stage of sepsis we have to implement therapy, and and what is the etiology which is driving the sepsis. So these are the few things we have to remember. In the meantime, Dr. Shruti, are you there?
Yeah, I'm here. I'm here. I was just climbing down the stairs from my clinic. So I was being
Yeah.
careful and I switched myself
Yeah.
off. So IVIG in sepsis, yes, the recommendation is not very strong. I agree with what Chandrima is saying. There are very few studies included and a few patients included. But yes, IVIG has a strong role where there is an immune mediated process happening. Because the main basis of giving IVIG, if you look at the way IVIG acts, is that if you have antibodies circulating in the system, the IVIG is supposed to adsorb to those antibodies. So the FC receptors of the IVIG molecules will adsorb to the antibodies against whatever immune situation is happening in the body, and that is how IVIG helps the control. So if you have TTP, if you have TMA due to autoimmune conditions, if you have lupus, these are the situations where IVIG will work better or will help you. And these are the situations where patients will improve with IVIG. Remember, IVIG is a very viscous solution. So sometimes you might end up with a trolley-like situation if IVIG is given. So we
Okay.
have to be careful when using IVIG. Plex followed by IVIG is a typical way to go for autoimmune phenomena or immune mediated processes happening in the body. So I would reserve the use of IVIG for only immune situations. Puneet, if you can put in some word about IVIG.
Yes, ma'am. As I mentioned, I agree with you. So they I discussed this before you had joined the use of IVIG in ICU in autoimmune conditions. Like
So
my
I have a important question for Dr. Shruti. Now, IVIG, how do you space IVIG with when you're doing dialysis and when you're doing a plasmapheresis? So this is a big question that physicians or
Yeah,
intensivists believe
yeah.
that
So
IVIG
then you
gets
have
washed
to
out.
got it.
So
So
I have one question. Does IVIG get washed out with the dialysis, with the
no,
cytosorb and
no.
any extracorporeal filters?
No, it does not, because IVIG is a very big molecule. Plasma exchange may be able to wash it out because it is an antibody grade, but none of the CRRTs or the extracorporeal circuits having auxiliaries or cytosorb or the normal dialysis filters will be able to remove the IVIG. How do you give IVIG? You give as 1 gram per kg or zero point 0.4 gram per kg. These are the two types of doses which are given. Zero point 0.4 gram per kg can be given in aliquots. So you can be giving 0.4 mg per kg. So a typical 60 kilo male or female will require 10 grams of IVIG. These 10 grams of IVIG has to be given over 8 hours. So it can never go fast. You can space it out to give every day and make it 1 gram per kg. Versus if the patient is on plasma exchange, then you can give it 0.4 gram per kg after every plasma exchange and dose it alternate days after the alternate day plasma exchange. Dialysis will not remove it. So irrespective of dialysis ongoing or not ongoing, you can give it at any time.
Thank you, ma'am. Thank you for the
See,
Now
sometimes there
coming
is
to the
one more protocol, if I can put in that, after 5 doses of plasma exchange, sometimes you can give a big dose of IVIG, 1 gram per kg. So 1 gram per kg comes to 60 grams. So 60 grams is 6 bottles of 100 ml of 10 grams IVIG each, which you can give over 24 hours. So this is one more strategy to give a big dose of IVIG. This can also be considered.
fair enough, ma'am. We'll go to the last paper, and we'll take comments from everyone at the end. Uh, Chandrima, can you quickly go? This is for Dr.
Yes.
Joycey.
This
Yeah.
paper is for Dr. Joycey. This paper was actually published in this year only, 2023, lately. And it has actually criticized the standard definition of massive transfusion in adults. The standard definition of massive transfusion in adults is usually transfusion of greater or equal to 5 RBC units in 4 hours, or replacement of more than 50% of total blood volume in 3 hours, or more than 3 RBC units during any 1 hour period in the first 24 hours. But however, none of these definition actually takes into account any other blood components or products or any hemostatic agents, which are also integral part of contemporary transfusion resuscitation. So a lot of RCTs have actually been taken into account for this trial until 11th of August, and 30 studies were analyzed. And what they found that most of their patients were trauma patients, followed by obstetric hemorrhage patients. And most of the places actually used the definition of more than 10 units of RBCs in 24 hours, while some places actually took 3 to 5 units of RBCs in 1 to 6 hours as the massive transfusion protocol. So there was a significant heterogeneity in the definition, and what the trial has criticized mostly that RBCs are the only component which have been used for defining massive transfusion, whereas they have put forward a thought that we should also consider platelets, plasma, and cryoprecipitate in the definition. We should also include fibrinogen concentrate or prothrombin complex concentrate and cell salvage as a part of definition also. And also the type of clinical setting should also be considered in the definition of massive transfusion protocol. So I want to ask Dr. Joycey her take on this article, and also I want to know from Dr. Joycey the method, the way, if a patient is having massive hemorrhage in our hospital, what is the way to go in our hospital?
Yeah, I hope I'm audible.
Yes,
Basically,
yes,
see,
ma'am.
for to begin off a massive transfusion or to initiate a massive transfusion protocol, a definition may not be important. Like we all know that a patient in hemorrhagic shock, or when they lose around 30 to 40% of blood, we have defined that in post-op patients we have defined a criteria, and we've defined in generally 30 to 40%. There's a massive you initiate a transfusion, massive transfusion. And there are various, at our place, mostly it is either a tech-based protocol. So pack cells, you ensure that your pack cells, FFP, platelets are at least in the ratio of 1:1, so that you do not have a DIC setting in. And this is very, very essential. You have to, the definition per se, I agree with the team, helps when you are evaluating a massive transfusion protocol later on. Okay. And it is very, very important to evaluate each of your massive transfusion protocol, because protocols set, if followed, would reduce the complications of massive transfusions. We know massive transfusions come with its own morbidities and mortalities, right from transfusion-induced complications to other complications, like you have a hyperkalemia setting in, you have hypocalcemia, you have your DIC setting in, you may have a TRALI, or you may have a TACO setting in. So it is very, very important to evaluate each of your massive transfusion protocol. And that is where the definition comes in. We have a challenge, when each time I discuss our massive transfusions in the hospital transfusion committee, very often often we have initiated a massive transfusion, but at the end of it, when you see, it doesn't fit into your definition. It doesn't fit in whether 10 RBCs have been going in. So should we incorporate in your massive transfusions? And that is when, after evaluating, if there are gaps, you need to close the gaps, because a massive transfusion protocol is going to be different in a trauma patient. It's going to be different in a post-surgical patient. It's going to be different in an obstetric patient. So each case needs to be evaluated. In our hospital, it is predominantly surgical, cardiac or vascular, gastrointestinal bleeds. These are all, liver trans. These are the predominant. We do not have much of trauma, and we have less of obstetric cases coming in. Predominantly, we face, so our management would be different. So we need to, that is where the definition comes in. And it's very, very important to follow protocols, because you would have complications at the end of massive transfusion protocols. That is, morbidity, mortality, everything rises. And that is why I think in general, we all need to review. And so that's why when we discuss in the HTC, I do not stick to the 10 RBCs per. I ensure, the first 3 or 4 hours. So if there is more than 3 units or 4 units, though our definition is different, our definition follows the general guidelines. But to discuss our protocols, whether we have been following protocols, we incorporate other units. And that is where the definition helps. If I would, Dr. Ketan and y'all manage there, so what would be your take? I feel there is where the definition comes in, not for managing a map, because your protocols needs to be defined. And if there is a gap in the present management, you can redefine your protocol. So suppose a patient has died off before the 24 hours, you may not incorporate. That's what even the study says. You do not include it in your massive transfusion. So you have lost a patient. You do not know why you have lost the patient. Was it because of a mismanagement, or was it due to something else? That is where the definition would help us. And so it's very, very important, because it's essential that you use all your protocols. It's only not RBCs. You have 10 RBCs, you would have a hemodilution coagulopathy. So you have to have your RBCs, FFP, platelets, and cryo to some extent when you need fibrinogen or prothrombin complex concentrates to replace your fibrinogen in the 1:1:1 proportion at least. So it's usually, if it is 6 Paxils, 6 FFPs, a dose of platelet or RDPs, and 10 cryos is what we usually follow. It may not be exactly 6. It is, many of our massive transfusions use a TEG. So they simultaneously monitor their TEG parameters and then ask for products. So I do not, as some hospitals, send 6 packs and 6. We do not follow that protocol. We follow a TEG-based investigation and then decide and send it. So I do not send in an MTP pack. We send in as the demand comes in, but our things are ready. Once an MTP is declared, we do not wait for, complete cross match, the typical pre-transfusion testing. It is ordered and we issue the product. That is what our hospital protocol, and it's a well-defined protocol that is followed. Though at times we do have gaps of miscommunication, which needs to be plugged in, at the communication. It is very, very important to have the primary team communicating with the blood bank. There is constant communication, otherwise things go wrong. So that is another thing that needs to be followed. You need not follow, the typical routine transfusion protocols, but you need to ensure that there is no hypothermia setting in. You need to ensure the acid base, the pH is maintained. You need to ensure your ionized calcium, you have to give. So you need to monitor your platelets, and which gives you with your TEG levels. So that is what my take on the definition is. Definition comes in the auditing of follow-up of MTPs rather than managers. So you set your protocols and therefore reduce the incidence of morbidity and mortality because of an MTP.
Yeah. I think, madam, that's a real life scenario you have described, and I would say blood products are the precious products, and
Yeah.
I think they have to be handled very judiciously, and there should be accountability for that. Having said that, the massive transfusion protocol, do you think there should be we have a criteria for that, but do you think there should be a code massive transfusion where
Basically, we had a discussion 2 years back, and we decided that a code may not help. There were numbers, but there's no harm. It's now 2 years down the line. There's no harm in revisiting the whole thing. and redefining, because now we know our take, where the gaps were, what was the problems with the present protocol.
Yeah.
We had defined that, we had given numbers, a single point of contact in the ICU or in the OT, whenever, and that was defined. But now it's almost in 2021, we defined the last and we are following the same protocol. We could revisit it and then take a call, all the stakeholders, the OT, the anesthetist team, the ICU team, the ER team could all sit together. We could redefine the entire protocol. So it didn't close. It's very essentially we define our protocols just to reduce your mortality and morbidity, because it's very, very critical. It's a critical stage we cannot change at that moment. So protocols needs to be defined. And 2 years down the line, it's high time, I think, we redefine it.
Yeah. One last question to you, madam. Suppose I have a transfusion associated reaction in my ICU. A patient has, I'm pretty sure that this is a transfusion reaction. What are the 5 important steps I should do by default? And how should be my communication with the blood bank?
Any transfusion, suspected, even a suspicion of a transfusion, I'm very, very clear about it. Even a suspicion of a transfusion, stop the transfusion. And you keep the line patent, you can start your management, but a post-transfusion sample of the patient, it with the bag, with a post-transition urine sample needs to reach the blood bank. Our primary aim during a transfusion reaction workup is there an ABO hemolytic, a hemolytic transfusion reaction, because that is the most catastrophic part of it. If it is not, then the others come in as ruling out. So if it is a hemolytic transfusion reaction, we need. So that is when we investigate in the blood bank, that is what we are ruling out, whether there is a hemolytic transfusion reaction. So if there is no hemolysis, then whether it be allergy, whether it be TRALI, it is like ruling out and ruling in. Like, you do other parameters and then set in, and the team opposite is then advised, and further product issued is based on this report. Suppose I have a patient who develops a febrile or an allergic reaction. The next, I would ensure that we would have either leukodepleted product or a plasma reduced product only going to the patient, with an advice that if it's a patient developed anaphylaxis, severe allergic, you need to cover with anti-allergens. That is a protocol that we follow. Now, in TRALI too, now that's like, the in thing nowadays. So TRALI as a protocol to prevent an incidence of TRALI, what in the blood bank we do is we do not use multiparas female plasma for transfusions. And that is known because they are the ones who develop anti-neutrophilic antibodies, anti-HLA antibodies, which is known to be a trigger. So that is one preventive measure we at our blood bank is taking. But still, you have an incidence of TRALI, it's like, you watch, it's more of a clinic. You have somebody develop breathlessness, somebody who have a chest x-ray, a TACO is ruled out. You could suspect, but to reduce the incidence, it's a precautionary measure done at a blood bank. We do not add.
And you got muted. I think you're on mute, madam.
Yeah. Hello, am I audible?
Yes,
Yeah.
ma'am.
Hello?
Yeah.
Yeah.
Yes.
Yeah, madam.
Anything else? Yeah. So that is necessary, that stopping a transfusion, except for in case if you have a mild allergic reaction, like a localized urticaria, you may stop the transfusion, manage it, and continue. Anything else beyond that, even if it's a 1 degree rise in temperature, necessary to stop the transfusion, return the back, because a hemolytic reaction is even presented with just a mild rise in temperature or just an uneasiness in the patient. So it's safer to be overcautious rather than take it for granted. That is all. Because a hemolytic transfusion reaction, right, the commonest thing is a clerical error. So either, so that's the first thing that we rule out. We do a complete blood group, we do whether there's any antibody developed, we do a direct Coombs test to test it. So that is the first thing that we rule out, and then we could go ahead with it. Hello?
Yes, ma'am. You're audible.
Yes. So y'all could put in your thoughts. What else needed? If anything needs.
No,
Hello.
ma'am.
Yeah.
Hello.
Yeah, thank
Yeah,
you. I
yeah.
think, madam, that is quite extensive elaboration. Uh, Dr. Shruti, thank you for your contribution, and I think it was a wonderful discussion.